Hello, everyone. My name is Anthony Ingram, DMP student here at Maryville University. I will be presenting my DMP project, Postoperative Sleep Promotion, a clinical practice guideline development for the advanced practice nurse. My chair is Dr. Robin Hendricks. Second reader is Dr. Boniface Stegman, and my community member is Dr. Jessica Machachi. A little background and significance. Sleep disruption is a common problem in the hospital, especially in a postoperative patient. A little background about me. I am a advanced practice nurse now, and I'm an acute care. I work in a surgical intermediate care unit, and a lot of times the patients do end up having delirium, lack of sleep, and it interferes with the treatment modalities that we try to bring or to get them out of the hospital at a reasonable time. The research says that over 47% of patients have sleep loss, which is an average of about 60 nightly interruptions. Sleep disruption is often overlooked despite its clinical impact. I did also read that the United States loses about 180 billion annually on healthcare costs that are contributed to sleep issues. And poor sleep is linked to delayed healing, increased pain perception, impaired immune response, delirium, prolonged hospitalization, and decreased patient satisfaction. Sleep promotion strategies are inconsistently implemented and they lack standardization. So an advanced practice or an evidence-based guideline for the advanced practice nurse working on these units, resulting in a variation of care and missed opportunities for recovery optimization can help. The project aim is to develop an evidence-based clinical practice guideline to guide the advanced practice nurse in improving sleep quality in the hospitalized postoperative patient. The research question that began with this project was, can a sleep promotion clinical practice guideline improve the consistency of sleep promotion practices among APNs caring for postoperative patients? My review of literature starts. So the evidence is supporting these interventions is very strong. Much of the literature informing the clinical practice guideline consisted of RCTs, randomized controlled trials, and we know that they're considered the gold standard for evaluating clinical interventions. 16 primary research articles were reviewed, and 11 were classified as level 1 or level 2 according to the Johns Hopkins Evidence-Based Practice for Nurses and Healthcare Professionals appraisal tool. A little bit more research. Insignificant sleep contributes to respiratory dysfunction. It weakens the immune system and it disrupts metabolic processes. It is associated with delirium complications. Several key factors influence sleep quality during hospitalization. That's excessive noise, especially in the hallways, in other patients' rooms. We have a lot of alarms going off. Room occupancy, having multiple patients shared rooms. You can also have where some patients have family members that stay overnight. Their anxiety is just as high as the patient's. Internal factors that come from the surgery. You might be dealing with pain, anxiety, everyday experiences from these hospitalized patients just compromise a restful night. These patients they struggle to achieve restful restorative sleep, and that's very vital for recovery, especially postoperative. Evidence-based interventions that could help in this issue is reducing the noise. I did read about some patients could get earplugs, having times, the 10 p.m. to 6 a.m. sleep promotion time that you see sometimes in these units for the quiet halls, light control, clustering care. Sometimes that's very hard to do when nurses have to treat the patients throughout the night, throughout the day. Sometimes this just can't be avoided when treatments have to be given at certain times. Relaxation techniques, family presence again. Are they there? Are they not? Are they being a hindrance? Are they being a help to cut off the lights, cut off their phones, cut off the TVs, sleep hygiene protocols, and then, of course, non-pharmacologic strategies are the ones I just spoke about, but they would be first line. In some cases, you might have to go to pharmacological therapies, but those are the ones that we end up having more issues down the line, the delirium, the confusion, and the somnolence that could lead to falls and then longer hospital stays. Theoretical framework also use the Johns Hopkins evidence-based practice model. It definitely supports this initiative. It's a model that translates high quality evidence into clinical decision-making outcomes. It's a facilitating connection between research and clinical concepts, and it provides a clinical approach to addressing real-time issues in hospitals through a systematic, stakeholder-driven process. Methods and design. With the Johns Hopkins EBP, it is based on the PET process: practice, evidence, and translation. This model aligns with the project's goal in improving recovery by enhancing sleep quality during postoperative care. And that will be done through phases of the literature review, which was very extensive, clinical practice guideline development, and the guideline evaluation, which was done by the appraisal of guidelines for research and evaluation agreed to instrument. The focus, translating evidence into practice. This CPG was developed and it aligns with the project that was already done, the 2018 Critical Care Medicine Guidelines for Prevention of and Management of Pain, Agitation, Sedation, Delirium, Immobility, and Sleep Disruption in the ICU patient. The setting for this project was a level 1 teaching hospital in the surgical intermediate care unit. It's a 32 bed unit, and 9 of those beds are dedicated to surgical IMC. And this is an adult postoperative population. The sample, we did not involve any patient information or any patients. This project was geared towards the advanced practice nurses working on the unit. And there were 4 reviewers that did the agree to tool, and the inclusion was just that they were a part of this unit. Data collection. So the agree to scoring tool has 6 domains to evaluate a clinical practice guideline that's been developed: the scope and practice, the stakeholder involvement, the rigor, the clarity, the applicability, and the editorial independence. Data analysis was descriptive statistics, the agreed to domain scoring, which is scaled in percentage, the global quality rating from 1 to 7, and the stakeholder feedback analysis. I was able to summarize the developed clinical practice guideline that I made in this project. This is just a snapshot of how it flows, which can be given. I have the full practice guideline per request, but just to go through it: patient eligibility, adults greater than 18 years old and the surgical IMC, pre-night assessments. We want to see if there's anything we can do about pain, predict nursing needs. And then we want to cluster care, make some environmental adjustments, which was previously spoke about, maybe earplugs, eye mask, set monitors so that they're not continuously going off, pain and symptom management, optimizing multimodal pain regimens, pharmacological sleep aids, patient care education, speaking on this sleep promotion, why it's important, helping patients to understand that they are in a post-operative setting And it's not that they're home and they have to, cut off the lights a little bit earlier or cut the phones off because it's only going to hinder more. And then documentation that the patients are getting this bundle of sleep promotion that is checked off each day by the nursing. And then if this CPG is implemented, which this project was just the development and scoring, but if it was to be implemented, that is also added to the clinical practice guideline. And it helps with the oversee of the rollout by the APPs or the APNs. It gives a description of training for the staff, which is about a 1 hour in service. There's a pilot for 4 weeks that adjusts in full rollout, a track process and outcomes measure, sleep quality, delirium, opioid use, length of stay, and patient satisfaction monitoring. This is a description of the results of the clinical practice guideline grading. They are scaled scores, and as you can see, they did score pretty high. The scale domain scores in the far right column, 92% scope and purpose, 76% stakeholder involvement, rigor of development was 72%, clarity 93%, applicability 79%, and editorial independence 96%. A little bit more of this explained. Scores were converted into percentages for comparison, and the high performing domains were the editorial independence, the clarity of presentation, and the scope of purpose. And then the moderate were applicability, stakeholder involvement, and rigor. That meant that the APPs accepted the performance with opportunities for improvement. And the key interpretation was that overall, this was a high quality guideline. It was strong in structure, clarity, and clinical relevance. And lower rigor reflects the need for more detailed evidence documentation. The takeaway is that the guideline is feasible, it's evidence-based, and it's ready for clinical use. And it supports standardization of sleep promotion practices. This is the quality scores and the recommendations for use by the 4 APNs. And all in all, they agreed that this clinical practice guideline could be used, but with a bit of modifications. So the clinical practice guideline was assessed by the agreed to tool. The feedback indicates strong acceptance. It could be improved. Collectively, the scores support the guideline's readiness, indicates that the APNs can implement the recommendations with confidence. However, the development score highlights the opportunity to strengthen the documentation of evidence appraisal and optimization of future uptake and sustainability. Limitations, there were only 8 for advanced practice nurses. It is a single site setting, and it's not implemented, so we can't really tell what the outcome data would be if it was used, and then it's limited generalizability. So in discussion, the original research question was, can a sleep promotion clinical practice guideline improve the consistency of sleep promoting practices among advanced practice nurses caring for the postoperative patient? The clinical practice guideline effectively addresses the practice gap. Strong evidence supports interventions. Positive stakeholder feedback came from the agreed to tool, and it supports standardization of care. Overall, working in the surgical immediate care unit, I can contest to patients not getting enough rest, becoming confused, and a lot of issues that hinder care. The patients do need this sleep. It is constantly an issue on my unit, and any patient staying longer than a post-op day 3 or 4, we start running into the delirium confusion issues, and patients are not being readily discharged from the hospital when they're supposed to be post-op day 1. So that's why this is so important. So the implications for practice, a clinical practice guideline with sleep promotion as the key would improve patient recovery. It would improve sleep quality. It would prevent delirium. It strengthens the advanced practice nurse's leadership. It promotes evidence-based care. One example is when I was actually training for advanced practice nurse, one of the physicians that I followed would always come and start a sleep promotion time. She put signs on the doors, but she would only work for a week. So between 10 p.m. and 6 a.m., patients were lights off, sounds off, decrease in alarms, no treatments throughout those times, clustering care, and those patients fared very well. But the doctor would only work for that week, so that practice it wasn't consistent. And the following week, that entire practice would leave, and she might not come back for another 3 weeks. These patients would basically decline back to the original practices of throughout the night, a lot of interruptions and not getting enough rest, which would hinder their quality of stay and lengthen their time in the hospital. So potential outcomes for the organization is, again, we would decrease the length of stay, we would decrease the complications associated, and increase patient satisfaction. The low cost and workflow-based interventions would also help as well. A lot of times I'm asked from nursing to give pharmacological adjuncts or medications to help patients get rest, to help patients decrease anxiety, to get them through the night. And often I have to say, no, let's try other things. But there's nothing in place to say that this is how it should be. And a lot of times you just lose the whole flow of work, especially overnight, because the flow is just to continue to go in the patient's room throughout the night, continue to wake the patient up, continue to interrupt positive. Once they're asleep, there's an interruption of their sleep quality. So they end up suffering. And there's also frustration that's involved with the nursing staff when they're trying to do their best. And we're trying to avoid the complications of pharmacological medications that could derail the patient even further or cause more harmful than beneficial outcomes for them. So in conclusion, sleep is critical to recovery, but it's often overlooked. Clinical practice guidelines provide a structured, evidence-based solution. Strong evaluation supports clinical use and future focus. If implemented, we would see outcomes of whether it's better or worse for the patient population to have a standardized guideline for the providers to implement. And though it would be a hospital-wide, stakeholders would have to be involved, everyone from the top to bottom, because a lot of times when you have these surgical patients, they're coming from teams that are specific to their surgeries, and their physicians, they want things a certain way. So it's kind of hard to say, well, we don't want to give medications that you prescribed at 3 o'clock in the morning, when the focus of that medication is probably 100% needed, but there's no budging on the time. So there's a lot of work to be done, but the evidence does support that this could work. The impact of the DNP program. I, for one, appreciate the DNP program at Maryville. It has taught me a lot. I did a lot of evidence-based research and education at my previous schooling, and it only enhanced it. The quality improvement process ability, it strengthened my clinical decision making, it introduced systems thinking, and prepared for advanced practice leadership. These are my references. and I appreciate your time. Thank you.